Welcome everyone. So we will just wait for the rest of the participants to come in, and then we'll start in a couple of seconds. So Fong, can we have the first slide? Hello to everyone. Thank you for joining us in today's webinar. Welcome to the fourth Symposium on Global Health Policy Research. I'm Kathy Reyes from the University of the Philippines, Manila. We started off this symposium last October 20 with a plenary discussion and followed this through with a series of webinars. We are now on our fourth panel discussion. Next slide, please. So we have had the first symposium in 2016, and this was followed by 27 and then in 2018 in Liverpool, with the objective of convening together our scholars and researchers who are doing studies on the theory and methods of social science in application to global health as well as global health policy making. And we hope that in continuing this discussion, we can continue to learn from each other and really build on the work of the scholars and understand more the nature of global health and global health policy making. And next slide, please. So after the 2018 symposium, a steering committee was formed, composed of my colleagues around the world, and I'd like to take this opportunity to introduce them to you. Karen Griffin is an associate professor from the University of Hong Kong. Aaron Mulaki is a policy analyst from the African Constituency Bureau of the Global Fund. Aaron is our vice chair for today's webinar. We also have Marcia Orgiel, senior researcher from the University of Cape Town. Carrie Scott, social scientist from the Johns Hopkins University, and Jeremy Schiffman, professor, Johns Hopkins University, and Stephanie Top, associate professor from the James Cook University. Next slide, please. And for those of you who are interested to connect with us as well as to view the recordings from our past webinars, this is our website. So we would invite you to visit our website. Next slide, please. I would also like to take this opportunity to thank our sponsors for the symposium, the Johns Hopkins Alliance for Healthier World, as well as the SHAPES Thematic Working Group of the Health Systems Global. I would also like to extend our sincere thanks to Fong from the Johns Hopkins University, who is providing technical support for all the webinars, including today's webinar. Next slide, please. So some of you may have already joined us from the first three panel discussions, and we have our fourth panel today. And I would just like to remind everyone that we still have a final panel happening on December 1, and you can still register using the link that you see on the screen. Next slide, please. And today's topic is very, very relevant and very exciting. And I'm really excited to hear from our presenters. So we'll be talking about the use of health policy analysis theory to analyze the politics of health systems governance. And I believe that most of us in this meeting tonight are very much aware about the importance of governance, and our presenters for tonight will show us in their study that can help us understand the use of theory in this field. So I am excited to present to you our panelists, and they will be presenting in sequence on the sequence that I'll be introducing them. So we would like to welcome Catherine Jones, a research officer from the London School of Economics and Political Science. Also, Gilbert Abiiro, lecturer from the University for Development Studies in Ghana. Also welcome to Shreya Hariyani, research officer from the Johns Hopkins Bloomberg School of Public Health. Kevin Croke, assistant professor from Harvard P.H. Chan School of Public Health, and Ankita Meghani, associate health systems program, Johns Hopkins Bloomberg School of Public Health. So they all have very exciting studies that I know will be very interesting for all of you. So each of our presenters will be presenting for around 10 minutes. After that, once we conclude all of the presentations, my colleague will be picking it up for the Q&A portion. So I would like to encourage all of you, if you have questions, to please use the Q&A function to please key in your question, as we will be looking at those and curating those throughout the time that our presenters are sharing the research. And then after that, we will be going through your questions. And with that, I would like to now start with our first presenter. Over to you, Kat.
Thank you, Kathy, and hello, everyone. So today I'm sharing the main findings from a scoping review on the use of theories and frameworks to study health financing policy change and processes in Sub-Saharan Africa. And I'll just preface this by saying that this paper has recently been accepted in health policy and planning. Next, please. Core texts for training, such as the methodology and health policy analysis readers produced by the Alliance, acknowledge the importance and benefits of using theories from political science to study global health policies. But despite agreement on this, researchers have found that theory is underused in health policy and systems research in low and middle income countries. Using policy process theories can help us to better understand the challenges and how policy change is navigated and negotiated, particularly when current guidance on developing national health financing strategies does not address the political aspects of this. Next. We asked this question with the objective to inventory theories and conceptual frameworks used in empirical research in this area, and to summarize the challenges, innovations, and lessons learned from their use. Next. This review was part of a larger project comparing policy processes in health and mining sectors in Senegal and Mali. We searched for English and French articles published between 2000 and 2017. 108 full-text articles were assessed for eligibility, as you can see in the Prisma chart on the right of the screen, and 23 were included for analysis. Those included met geographical criteria, importantly had the presence of policy process or a health policy related middle range or conceptual mid-range theory, or conceptual framework ex ante. And these definitions are provided for you in the middle of the slide, which we use to define what is a conceptual framework and what is a mid-range theory. For simplicity in the rest of the presentation, I'm just going to use the terms theories and frameworks. We also consulted with experts and first authors of the selected studies. Next. 23 studies concerned 16 countries in Sub-Saharan Africa. Ghana, Burkina Faso, and South Africa were the countries studied most in this literature. National health insurance, user fee exemption, and performance-based financing were the key health financing policies featured in these. Next. The resulting map shows the discipline or field of origin of these theories and frameworks and the names, as you can see here in the table. We found, in fact, a separate category of what we call theoretical bricolage that emerged from the analysis, wherein 8 of the studies involved authors combining theories and frameworks from various disciplines and or origins. So taken all together, including their use for bricolage, 15 of the papers we analyzed used a theory or framework from political science, and health policy and systems research frameworks were used in 7 of them. Next, please. So the 3 most cited or most used theories and conceptual frameworks are those that you see here on this slide. The y-axis shows the number of studies rather, that use these rather on their own or in bricolage, which you see in the purple. So Grindle and Thomas's Arena of Conflict is a framework of political economy of health reform on the role of policy elites in shaping policy agendas and managing political and bureaucratic challenges of policy reform in developing countries. Kingdon's multiple streams, perhaps a theory many of you are familiar with, is a theory of agenda setting, where attention for a policy problem on a government agenda is examined by identifying the coupling of issues, interests, and ideas when a window of opportunity is created for a policy entrepreneur to promote his or her policy solution. When it comes to the health policy and systems research framework, Walt and Gilson's policy triangle emphasizes the need to take into account of who is involved, the actors, how processes and decisions are made, what content is included in what the decisions are, rather, the content, and under what conditions, or the context. Next, please. So given that few authors in the literature actually reported the challenges or the lessons they learned when selecting, adapting, or applying theories and frameworks, the consultation phase of our review was in fact a really critical contribution to which 10 out of the 23 first authors replied. So in terms of choosing a theory or framework, access to and availability of examples of the use of that framework or theory in similar bodies of literature is as influential to researchers as their assessment of the usefulness of those concepts in analyzing the themes that they want to analyze. Francophone researchers particularly encounter additional challenges in this regard due to the limited availability of theoretical texts in the French language, but also very few empirical examples of how those have been operationalized in Sub-Saharan Africa published in French. Challenges in using theory relate to operationalizing those concepts, but also managing the theoretical inferences for the context of their inquiry in Sub-Saharan Africa. So despite consensus on the accessibility of frameworks like the policy cycle or the policy triangle for multidisciplinary use, those who are less familiar with analyzing policy from a political perspective actually experience great challenges working with these. So while these 2 frameworks are recognized as useful for description, they're found to be quite limited to support analysis that explains change. Theoretical bricolage offers great opportunity for learning and expanding our empirical knowledge, but these innovations in working with multiple theories require deep engagement. Generally, authors there was agreement across authors that the use of theories and frameworks was very helpful in orienting the collection of data, the organization of their study, and their analysis, but particularly these were found valuable to explore what a lot of researchers refer to as, a fuzzy concept, for example, differences between political and technical actors related to their policy change, or the differences between knowledge and systems in health financing. Next, please. So reflecting on these results, we looked at the public policy literature to see what could be learned to encourage more hybridization, or what's also being called in some qualitative circles as theoretical bricoleur. And there's a lot to be learned from that. However, when we think about some of the challenges around diversifying and expanding the use of policy theories and conceptual frameworks in this area, we might consider that there are also many pragmatic reasons that underlie health policy and systems researchers' choices for using some of this more simplified frameworks, such as a lack of time to invest in learning an unfamiliar theory, the need to publish results quickly, and also potentially being conceptually risk-averse with the desire to use what is widely accepted in the field, or adopting a very status quo approach. We've made a few recommendations in the paper, and I think those might be some things that we could discuss today in the larger discussion, but I want to point out that something that also arose from our work on this is that we're really thinking about how the epistemic power in the use of policy theory needs to be included in our wider reflections and actions on decolonizing knowledge structures of global health. And that's something that we're working on separately, an additional reflection piece, and that might also be of interest for discussion today. Next, please. So on that, I just thank you all and thank the organizers and look forward to further discussion.
Thank you very much, Kat. Gilbert, over to you.
Good morning, afternoon, and evening, depending on where you are coming from. So I'm presenting to you on a policy analysis with the title Fallout of a National Health Insurance Capitation Payment Policy from the Policy Agenda in Ghana, a regional level policy analysis. So this is actually an empirical study. Next. So this is the outline of the presentation. So let's go to the next page. So as a way of introduction, you know, capitation is a provided payment mechanism in which providers are often paid in advance. It's prepaid, and then services are delivered based on the amount that is paid to the providers in advance. So normally, in terms of reforms relating to capitation, for example, there are often controversial issues surrounding those reforms, and such reforms are often very contentious within low and middle income countries because they involve people getting benefits and others also stand to lose from those reform processes. So as a result, even if such reforms gain the attention of politicians and policymakers, and the political controversies surrounding them are not understood and addressed, there is a tendency that those reforms can drop off the policy agenda. So what I'm presenting to you today is a typical example of such situation, and I'm applying three policy analysis frameworks to explain why a national health insurance capitation payment policy, which rose to the policy agenda and was being piloted in Ghana, was suspended. That means fell off the policy agenda. And then what can be done in order to ensure that the policy regain political attention? Next slide. So just a brief context about the Ghanaian capitation policy reform. You know, Ghana started a national health insurance scheme around 2003, 2004. And then since the inception of the scheme, providers were often paid on the basis of fee for service and later using Ghana diagnostic related groupings. And it was observed that such payment systems were associated with escalating healthcare costs. So the National Health Insurance Scheme introduced a capitation payment policy in 2012, and it was being piloted in one of the largest regions, that's the Ashanti region. Also note that this region is dominated by the then main opposition political party, which is now currently the ruling government. So within the capitation policy that was being implemented, people who registered with the National Health Insurance Scheme were expected to choose one healthcare provider, like a facility, and then was assigned to that facility to receive outpatient primary healthcare. So this policy was implemented from 2012 on a pilot basis, then until 2015, when the National Health Insurance Authority argued that it had learned some lessons from the pilot and was planning to scale it up to the whole country. By 2017, there was a change in government, and then there were also a number of issues that were raised, and then the policy was suspended. So the argument is that as of now, the policy is still on the agenda of the National Health Insurance Authority, but it has lost political attention. So my study is to find out what actually led to the loss of political attention and what can be done to regain political attention for the policy to be implemented. Next slide. Next slide. Okay, so basically, I actually applied two policy analysis frameworks to collect and analyze the data. So that is the Schiffman and Smith framework, which is actually often used to explain how issues gain attention. So I rather use it to explain how the capitation policy issue, we already gained attention, lost the political attention. Then I use the Jinnah et al. Framework to explain what can be done in order to ensure that the policy regains political attention. So if you look at the Schiffman and Smith framework, so I adapted it in a way to argue that the components of the framework interacted within the Ghanaian context, and that led to what? The decoupling of the policy streams, that the problem stream, the policy stream, and the politics stream as presented by Kingdom, and then that led to the suspension of the policy. Then for it to be re-implemented, or for it to regain political attention, then there's a need for a reframing. So I try to explore these issues in the study. How can it be reframed? Then what can be done to create political opportunities, and what resource mobilization will be required for the policy to be re-implemented. So this is basically what, so the results will reflect on that of the Schiffman and Smith components, and then that of the Jinnah et al. Component. But the Kingdom aspect was actually used in the discussion to demonstrate how the Schiffman and Smith components interacted in order to decouple what? The three streams, and hence the fall of attention on the policy issue. Next slide. So in terms of methodology, this was a retrospective policy analysis. So the data was actually collected in 2019, and it was conducted in Ashanti region. The reason being that that was the region where the policy was being piloted. So in terms of methods, so I actually conducted 18 key informant interviews with regional and district level, as well as facility level policy actors. And I conducted 4 focus group discussions with community level policy actors. These were people who were registered with the National Health Insurance Scheme within the period in which the capitation policy was being implemented. The information from the field was triangulated with media reports. There were a lot of media reports on the policy issue. So I gathered the media reports and triangulated the field data with the media reports. So in terms of analysis, all the data was recorded and then thematically analyzed. Next slide. So, I'm going to present the results to you, and the results will be in 2 parts. The first part will explain why the policy fell off the agenda, and the second, using the Schiffman and Smith model. And then the last part, the second part will try to explain what can be done using the Jinnah et al. Framework. So next slide. So in terms of the Schiffman and Smith model, what led to the close of the policy window? So first is an issue of framing, how the policy issue was framed and presented to what? The various stakeholders. So I discovered that there was a kind of a clash between the technical framing of the policy as a strategy to contain cost, and then a political reframing of it as a strategy to actually punish people who were members of the opposition party, as well as providers who were perceived as what? People who fraudulent. So this was the case. You know, the Health Insurance Authority actually conceived that probably there were a lot of weaknesses within the existing provider payment system. That was why the cost was escalating. So introducing capitation would try to check the loopholes that were in the system. So when providers heard this, and because it was being implemented in Ashanti region, which was the region that was dominated by the opposition political party supporters, then they argued that if that was the case, and you are bringing it to our region, that means that you are pursuing, you are seeing that because we are opponents to the government, then that is why you are bringing it to punish us. So you are also saying that the providers within the Ashanti region are fraudsters. That's why you are bringing capitation to introduce in only that region, but not in the other region. So this was a problem. Though technically the objective was cost containment, but politically it wasn't, the frame did not reflect very well with the people at the local level. Next slide. So as a result of that, the various stakeholders that are actually covered in the study took different positions on the policy. In terms of the policy idea is that whether capitation was a good policy for the Ghanaian context, there was wide support across various stakeholders, apart from the national insurance clients who felt that no, they didn't like the idea of being restricted to one facility. All other stakeholders within the political realm, as well as the technical stakeholders, all argued that the concept itself was a good concept and supported it. However, when it came to the pilot implementation, a lot of the stakeholders, especially the political ones, argued that, for example, those that were in the opposition party argued that the choice of the region was not appropriate based on a number of reasons. One, because you are doing a pilot scheme. So a pilot scheme shouldn't be implemented in a region that is as large as the Ashanti region. And second, because that is the dominant region in terms of what support for the opposition party, like choosing that region also brought a different view. So people thought, no, that wasn't probably the best region to start with. But the Health Insurance Authority also had a technical explanation because that region is centrally located and there are a lot of people from different backgrounds that are located in that region. Now, in terms of the pilot implementation, the stakeholders were divided. Some opposed it and some supported it. The major opponents were actually the then opposition political party, the NHIS clients, and then that of the providers union. Some of them actually strongly opposed it with various reasons that were given. Then now when the policy was suspended in 2017, you could see that apart from a few stakeholders who actually resisted, who argued that no, there was no need to suspend the policy implementation. A lot of them actually said that yes, it was good to suspend it and then rethink and then try to redesign it and then bring it back in a way that it will reflect the interests of many stakeholders. Next. So in terms of the policy characteristics, as outlined in the Schiffman and Smith model, it was discovered that there were a number of characteristics of the policy that were very contentious, they were poorly understood, and they were actually not even well implemented. Some of them included the capitation rate. And all the providers didn't even understand how the capitation rate was calculated, and perhaps they argued that the rate was very low. Then also in terms of portability, so if you are registered and you are signed to a facility within your district, what about if you travel outside and there's an emergency, what happens? And then a number of other issues. Although some of these issues were incorporated into the policy, but because probably the education wasn't very well done, so the beneficiaries argued that they were not well informed about them, and as a result, some people resisted the policy because of those characteristics. Now, in terms of the political context, it was clear that the choice of the region, which was a dominant region for which was dominated by opposition political party supporters, was not the best choice because it did not create that kind of enabling political climate for the implementation of the policy. So when stakeholders started agitating against it, the then opposition party actually supported the stakeholders who were opposing it and formed alliance with them. And it even came during an election that was supposed to take place in 2016. And then the then opposition party argued that it will cancel the policy if it was voted into at par. And indeed, luckily for the party, and then unlikely for the policy, the then opposition party won the election in 2016 and formed government in 2017 and went ahead and suspended the policy. So there was a very strong political influence in the suspension of the policy. Now, so the argument now is that all this, the problem that was being observed as that of something to contain cost. Because of all these dynamics that came in, people tried to reperceive the problem. There were issues about restricting people getting access to healthcare, which people thought was not good, and discriminating against a particular region because it was piloted for about four years and not scale up. So because of all the people started perceiving the problem. So then that is where the kingdom model comes in, perceiving the problem. So what was seen as a problem, it became a different problem, and the solution was perceived differently, and that led to the suspension of the policy. Next slide. But the argument is that the National Health Insurance Authority that initiated the policy was not the one that suspended it. This was a political decision. So it is still on the agenda of the National Health Insurance Authority. So what if the Health Insurance Authority still insists on implementing the policy? What is required? So in this case, I applied the Gina et al. Model, and then I actually collected data from the field. These are some of the quotations that are there. And one of the things that came out strongly was that if the policy will be re-implemented, there's the need to rename it. It shouldn't be called capitation, because some of the stakeholders argue that the word capitation has been slaughtered. So when you bring it back, people will oppose it just because of the name capitation. Can we get a name that is not capitation, but probably that conveys the same objective of the policy, and then the debate surrounding it, the policy, the education should not just focus on the fact that it will contain cost, but to hammer on the medical benefits of staying with one provider and not hopping from one provider to the other. The next point, also in line with the Gina et al. Model, is how to create fresh political opportunities for the policy to be implemented. It was a new era with new stakeholders, both at the political and out of the technical level. So there is a need for re-engagement, broader consultation, and effective education on the policy issue so that political support can be re-won for the policy. Now, one of the issues that came out strongly was the fact that the primary healthcare facilities in Ghana that are supposed to be the main point of call and the baseline for that of the capitation policy have been under-resourced. And then the referral system, which is supposed to enable the capitation system to work very well, was not very functional at the local level. So the question is, can you actually implement a capitation policy without resourcing the primary healthcare facilities and strengthening that of the referral system? So that, again, is supposed to be done before the policy can be implemented. Next slide. So in conclusion, so I conclude that in line with the Schiffman and Smith framework, inappropriate policy framing, the existence of a very strong anti-policy community of actors at the local level, and the existence of very contentious and poorly implemented policy characteristics, as well as unfavorable political environment, created the political window for the suspension of the policy. So in line with Jena et al., if it will be re-implemented, there's a need for a reframing, there's a need of mobilizing additional resources in terms of resourcing local level facilities, and there's a need for what? New, fresh political engagement with the policy actors. Next slide. Thank you very much. That's the end.
Right. Thank you, Gilbert, for that presentation. Next, we'll have Shreya. Before Shreya starts, I would like to remind everyone to please key in your question using the Q&A box. We already completed 2 presenters, so if you have questions for them, please write them on the Q&A function. Now let's welcome Shreya.
Oh, sorry. Okay. Greetings to everyone. I'm Shreya, and I'm a research officer with Johns Hopkins, and I'm based in Lucknow, Uttar Pradesh, India. And I'm going to be talking about the experience of using stakeholder analysis as a method in the development of a human resources for health strategy for the state of Uttar Pradesh. So next, please. So just to give everyone a quick background about UP and the project that we were working in. UP, as many of you may know, is India's most populous state with a population of over 200 million. And like in other LMIC settings, experiences a set of challenges with the public health force, such as an acute shortage of health workers. So you can see here that in UP, the estimated density of health workers is 7.8 per 10,000. Compared to 29.2 for India, and way below the WHO benchmark of around 44. Apart from an acute shortage, there's also challenges around maldistribution, performance, governance, and management of health workers. So in this background, the government of UP, wanted to develop a comprehensive HRH policy for the state of UP. So in partnership with the UP Technical Support Unit, which is an organization that supports the government of UP, and our team, we worked on developing this state HRH strategy. And today, I'll be trying to draw out of some of the lessons that we learned in applying this method, prospectively in the development of the strategy. So next, please. So just to talk a bit about the methods, we had a draft set of distinct policy options that spanned across the human resource life cycle. So that included right from production, recruitment, retention, and performance of health workers. And we sought both individual and organizational perspectives on these set of policy options that we had developed through in-depth interviews, focus groups, as well as observations. So listed on the column on the right, we have, the range of respondents that we engage with. So it includes government officials, frontline workers, but also, outside the government, civil society organizations, the private sector, as well as training institutes. And for the analysis, we focused on understanding what was the sort of power and influence that some of these stakeholders had over, HRH, and as well as what were their positions on the different policy options that we were talking about, as well as some of the barriers and facilitators to these policy options that we were proposing, so that these could be factored in moving forward in the policy development process. Next, please. Right. So jumping straight into some of the key lessons that we learned, in applying this in applying the stakeholder analysis. So I think there's an increasing recognition to move away from the centers of decision making and engaging more with frontline stakeholders as well as expanded networks. So moving beyond, even though it was a state policy, but to engage with the private sector, for example, became really important. So if we see this, from this group discussion from with medical officers, they also highlighted the fact that policies were often developed without taking into account ground the situation at the ground level, the experts and the manpowers necessary for implementation. So in that, with that, we found several instances of contestation. So, for example, with policies around improving living and working conditions for health workers, we found that these set of policy options were really important for frontline health workers, and to the extent where they said that if this was solved for, a lot of the other policy options that we were proposing wouldn't be necessary. But if you moved up and went closer to the more senior leadership, while they recognized that yes, living and working conditions need to be improved, they didn't really see those as policy priorities. So that's an example of how there might be a need for more extended negotiation between the front lines and the center, and that's where a stakeholder analysis could be useful. Moving on to thinking about expanded networks, we found that initially engaging with the private sector, for example, they resisted commenting on policy options because they were like, oh, this has nothing to do with us. But what we found that on further probing and respondents then started to think about policies in a more integrated fashion as a part of a wider system, and we got some very interesting insights from those conversations. Another example for in UP, beyond expanded networks, is that even within a fragmented system, where there are within the medical health department itself, there are 3 or 4 separate directorates, with separate responsibilities. So we also found that within the government system itself, departments would often not want to comment on policies that was not in their direct implementation control, even though those were policies that they could have an influence on. And lastly, in seeking perspectives from association or union leadership of health workers, we found that these were often different, and we got quite a lot of valuable insights in terms of engaging directly with frontline workers, but also understanding the perspectives in terms of power that comes with an association or a union leadership. So next, please. So, apart from, thinking about, you're just going forward and thinking about the strategic engagement with stakeholders. Another experience that we had is that, for a set of policies that was particularly contentious, related to, for example, transfers of local administrative or clerical officers that are based at the facility level or the local office level, and they're not usually transferred. So they have a lot of local level power. So in those cases, we were advised that, rather than engage, so there's an association of those workers as well. So we were advised to not engage with that association because of their power, because around fears that, some of these policies might be shut down if we engaged with them too much in advance. So here we sort of, for us, it was, this tension in terms of balancing inclusivity and getting perspectives from stakeholders who the policy influence, but also being strategic about when to engage with them. So I think that's something I think would be interesting to discuss. Next, please. And lastly, we also reflected a little bit upon our role, like as a policy research team. We often came across, in engaging some of the more senior leadership, which in some sense had also commissioned us to, do this work. So, we often found them telling us that, you all are the experts, and there was an expectation that we would provide prescriptions. So when we, tried to seek, their perspectives on the draft set of policy options, they still, felt that, oh, this is not something that we should be commenting on at this point. You just give us, what's required. But we realized that in this process, it was important to build, a lot of trust into the process. And we also did something else where we formed a policy working group that had representatives from the government, and also the local partners, the UPTSU that was involved, as well as our, researchers from our team, some of us who were based in India and were familiar with the context, but also, more senior faculty. So I think having that kind of a diverse working group sort of helped push through the process of conducting the stakeholder analysis. Another area, where we thought, where we had some amount of reflection was that, as researchers, we're often, wanting to promote policies that are bold, innovative, but through the process of the stakeholder analysis, you might find that, these are some of these are actually quite complicated to implement. So how do we sort of resolve, this sort of, putting these recommendations forward? And lastly, we also, wanted to stress the importance of building reflexivity to the process, thinking about the positionality of the research team and how that influences data collection and analysis. Next, please. So in conclusion, we found that stakeholder analyses actually turned out to be a very useful tool in the policy development process itself. So using it prospectively, along with the other, other technical assessments of policies and other processes. It was really important because it helped us identify several implementation challenges that we could factor in while designing some of these policies as well. But going forward, just sort of summarizing some of the lessons that I already talked about, I think more reflection around challenges, for this need to pursue more bold policies and balancing, the implementation considerations that come out from a stakeholder analysis. And apart from that, I think just a more broader need in this, policy environment to create, more buy-in and understanding around the process of, consultation with, different groups, including extended groups of stakeholders, and, balancing. But there's always going to be that tension between balancing time sensitivity and deliverables, and, having an inclusive and participatory policy development process. So that was really all from my end, and I look forward to hearing from the panel and the participants. Thank you.
Thank you very much, Shreya. And I also really appreciate that reflection as a researcher, and maybe we could have that in our discussion later on. Now, let us welcome Kevin.
Thank you. Thank you, Kathy, and thank you, everyone. I'm going to speak today about Ethiopia's primary healthcare expansion. I'm going to do that from the point of view of state building and health system strengthening, and hopefully in doing so, speak to some of the themes of the panel about bringing theory to bear on key questions of health systems and health system strengthening. Thank you. Next slide, please. So when I speak about the primary healthcare expansion in Ethiopia, I think I'm talking about a policy phenomenon that many of us in global health have become familiar with. So the Health Extension Worker Program in Ethiopia is probably the most well-known example of this. And this is starting in 2003 or 2004. Over 30,000 health extension workers were hired, trained, and deployed in Ethiopia. In conjunction with this, there was a large investment in infrastructure and health facilities. So more than 15,000 village-level health posts were constructed to house and provide a place for these health extension workers to be based. And then at the next higher level of the health system, there were more than 2,500 health centers constructed, and similarly a large investment in district hospitals and in higher level health cadres. And so overall, this has become quite a high profile policy example in the global health space, and even to the extent that our current Director General of the WHO, Dr. Tedros, is often credited with his role in this policy as one of his main achievements. So I think it's a well-known policy. And so naturally, countries look to understand it, and many that also seek to implement primary healthcare look to Ethiopia as a model or as an example of what can be achieved. And so I think as analysts, we might look at this and say, what were the underlying conditions? And if you look at both the articles written and the speeches made by the architects of the policy themselves, and also by analysts and researchers, they often talk about political will and decision taken at the highest levels to prioritize this. But what I seek to do in this paper is to unpack this concept and to really say, what are the components of political will and where does it come from? Is it a kind of idiosyncratic, in some sense, fortunate happenstance, whereby a country ended up with a really dynamic minister of health or a president who was committed to a certain health policy? And if so, that's probably of limited generalizability, or are there deeper underlying structural factors which can be understood? And I really want to put emphasis on the processes of not just policy adoption, which I think much of the health system literature focuses on, but also policy implementation. And in support of that focus on implementation, I'm going to emphasize the politics of building the state and building the state in rural areas. Next slide, please. And just to situate this, so this is a single country case study using many of the methods that that other presenters have mentioned too. So key informant interviews and review of the secondary literature. But speaking to the themes of the panel, what I tried to do in this project is to really embed this project in theory, and in this case, sort of two sources of theory. So since Ethiopia is a kind of positive outlier in this sense of a country that managed to scale up and implement primary healthcare at quite large scale, at national scale, I think we can situate it theoretically by looking at the retrospective literature on countries and cases post Alma Ata. So in the period after primary healthcare was a global goal, there's a large retrospective historical literature, public health literature on why many of those primary healthcare programs ran into challenges, ran into roadblocks, didn't achieve their goals. And so I try to synthesize those different accounts into a set of theoretical reasons, and then why those programs did not achieve their goals, and then say in each of those, for each of those categories of reasons, what was done in Ethiopia, how did Ethiopian policymakers surmount those barriers? And the second source of literature and theory is really the literature on the post 1991 Ethiopian state. There's a political science literature that focuses on that state building process. And what I hope to do is bring that political science literature. It's not usually the political science literature that we draw most on in health systems analysis, but I think it's quite critical. And then the second part, this is a companion project with an empirical set of empirical papers with Kibram Tafre, Andwal Mengistu, and Stephen O'Connell, in which we look at the effects of these policies. So we exploit variation in the timing and the geography of primary healthcare scale up to actually look at the impact of the programs on health access and health outcomes. So in a sense, we're trying to understand where the policies come from and then what the effects of the policies were. Next slide, please. So I mentioned that one of the goals of the project was to distill these challenges to primary healthcare in other countries into a set of 4 challenges. And I think you can usefully classify those challenges as related to distributional politics, related to state capacity, related to finances, and then related to ideological or ideas-based opposition to primary healthcare. And so what I'll do for each of these is just mention the general challenge, and then how Ethiopian policymakers address that challenge. So the first is distributional politics, and this comes through very clearly in the literature on PHC. And the idea is that reorienting your health system to PHC is often unpopular with elites. So, urban middle classes, economic elites, civil servants, and often even medical elites do not want the health budget reoriented towards low-cost care delivered in rural areas. And so understanding how that shift was made in Ethiopia, it really comes into focus when studying the evolution of the political strategy of the former ruling party, what was the EPRDF, and the group, the TPLF from Tigray, and the accounts of their emergence over time really stress that their main political strategy was to prioritize rural populations. And this comes out of their wartime experience in the long period in which they were in insurgency. And they saw prioritizing rural over urban interests as essentially their key political strategy. And this included running, during the conflict period, running a primary healthcare and community health worker program, which I argue is a fairly clear precursor to the national program that gets implemented after 2003. The second challenge is state capacity. So running a large-scale primary healthcare and community health worker program is a major implementation challenge. The state has to monitor a large group of geographically dispersed workers, and this is kind of the core of state capacity. And so in Ethiopia, there were many strategies which were done to surmount this challenge. But one was a major investment by political leaders and by policy elites in state building and party building at local level. And so investing in Warada, which is the district and sub-district level, the Kabele level state, and civil servants and administrators based at that level. The second strategy is directly overlaps with the strategy of health extension workers at community level. And this was the idea that building the state was not just a project of investing in district level government, but also mass mobilization of the rural population and organization of that population into a series of what were called development teams. In the health sector, this was called the Health Development Army or the Women's Development Army. And this extended even down to what were called the 1 to 5. So a model household for every group of 5 households. And this may seem to speak to exactly what health sector policymakers always want to do with primary healthcare programs: reach people in their homes at the lowest level in the community as possible. This overlapped directly with what the state and the regime wanted to do, which was to incorporate the rural population into their political and administrative structures. The challenge here is that this was politically controversial in many regions and increasingly controversial in the context of the post-2015 political unrest, and likely to be, given the tragic situation unfolding right now. One can only imagine this controversy continuing. And next slide, please. The third issue is financing. So we often think about, as global health policy researchers, we often think about PHC as being a very cost-effective thing to do, but a national PHC program that involves investment in facilities, health workers, faces a huge financing gap in many settings. And the way this was addressed in Ethiopia was with very, very skillful management of donors. Many of the donors who in other countries were very, very set against investing in facilities in the health workforce, in what are sometimes called horizontal or health system priorities. But the leaders, Ministers of Health and the Prime Minister at the time, essentially convinced many of these donors, including the Global Fund, Gavi, and a large group of bilateral donors, to fund a lot of the investment costs of the community health worker program and of the other elements of primary healthcare, including the construction of the 2,000 or 3,000 health centers that I mentioned. So this is essentially how the financing gap was filled. So also critically, the health extension workers they're not volunteers, they're employees of district budgets and of district governments, and this I think gives the program a greater degree of sustainability. But the budgetary cost is still more than the government can afford, and so this skillful this kind of repurposing of donor agendas to their own agenda was critical. The final obstacle that I'll mention is the ideological element. So, all accounts of how primary healthcare fell off the global agenda, after Alma-Ata mentioned this kind of global ideological turn against the public sector, and this idea that hiring large numbers of primary healthcare workers into the public sector, especially at the time that the Ethiopians began, was highly controversial. But there was this was, I think, very directly emerging from the Prime Minister at the time, Meles Zenawi's view of the developmental state, which envisioned a very important role for the public sector. So these ideological barriers did not get in the way. Next slide, please. Just to conclude, I'll try to summarize this by saying, I think political will, as we often think about it, is not, I think this case shows a single decision or a moment when a policy is adopted, but it's a process with deep historical roots. And I've mentioned the roots of the health extension worker program in previous programs during the period of conflict, and specifically health extension worker programs. But these historical roots also demonstrate the role of contingency. So even though there are deep historical roots to these programs, they did not emerge on the policy agenda, for example, for the first 10 years that the EPRDF was in charge in Ethiopia. It was only after a split within the ruling party and consolidation of power around then Prime Minister Meles Zenawi that these health and other rural-focused programs emerged. So historical trends, but also individual agency and contingency. And I think the broader political question, which given the the very worrying developments right now in Ethiopia that this calls attention to, is that health system strengthening in some ways is a project of state building, and state building is contentious. And this developmental state project, of which health was a part, did not resolve the kind of underlying national question in Ethiopia and the tensions around national political power. And so, just to conclude, I'd say that the Ethiopian model is often cited as something for countries to emulate and achieve, but I think it's important to consider it in its full complexity, its historical context, with both the costs and the benefits of that model. Thank you.
Thank you very much, Kevin, for that very interesting presentation. Now, let's all welcome Ankita for the final presentation before we open for Q&A.
I realized I was muted. Can you hear me now?
Yes.
Okay, great. Thank you, Kathy. It's a pleasure to be participating on this panel today. I'll be presenting findings from one of my dissertation papers, and on behalf of an amazing team of collaborators at Johns Hopkins Bloomberg School of Public Health, as well as the UP Uttar Pradesh Technical Support Unit. And as indicated in the title of this talk, my talk today will focus on understanding how, when, and why administrative data are misreported in Uttar Pradesh, India. Next slide, please. So before I talk about the issues around data misreporting or data manipulation, it's important to highlight that this study was conducted against the backdrop of a health management information system, or an HMIS reform in Uttar Pradesh. And specifically in 2015, there was a renewed effort by the government of UP to strengthen the performance of its HMIS. And this HMIS reform had two main components. First, the government wanted to improve HMIS data quality. And second, they wanted to improve HMIS data use in decision-making. Next slide, please. First, to improve data quality at the district level, the government established monthly data quality meetings to ensure that these data were of good enough quality before they were used and reviewed during the monthly program review meetings, which were led by district chief medical officers and district magistrates. And second, to promote the use of HMIS data during these program review meetings, the government also developed monthly district rankings. And the government also mandated the review of these monthly district rankings during the program review meetings for two reasons. First, they wanted the district leadership to use the district rankings as a way to monitor performance of different health programs, but they also wanted the district leadership to look at the district rankings, identify the low performing indicators, and then on that basis, develop action plans to improve their performance. Next slide, please. However, what we found was that based on our formative research and a policy implementation study we conducted, that these new HMIS policies were actually being unevenly implemented across the district level in UP. And we also found that in some situations, HMIS data were also being intentionally misreported or even being manipulated in order to show a higher district ranking. So it was really within this context that we became very interested in understanding and unpacking why are HMIS data being manipulated and what are those underlying drivers of data manipulation. And to answer this question, we did in-depth interviews at the district level, at the division level, as well as at the state level. And we also observed district level meetings, both the data quality meetings that I talked about, as well as the program review meetings where those validated data are meant to be used for decision-making. Next slide, please. So in this study, we defined data manipulation as the fabrication or alteration of data done with the aim of furthering one's personal interests or to cope with systemic pressures. Next slide. And through our interviews, particularly at the district level with district level respondents, we found that there were 4 types of data manipulation that commonly happened. So respondents told us about how data or specific indicators were overreported. And often this had to do with the overreporting of closely monitored indicators, such as the district ranking indicators, or indicators that were associated with financial incentives, or that were associated with a national campaign that might have been running that month. We also learned about the underreporting of negative indicators that could potentially reflect poorly on a health worker. So for example, the reports of maternal deaths. We also learned about retrofitting of data to match inventory data. So often this happened with data on health commodities like oral contraceptive pills or multi-dose vial vaccines or vaccine vials. And then finally, we learned about the hiding of data. So information around low performing indicators was often hidden from presentations with meetings with superiors. Next slide. So after we identified the different types of data manipulation, we became really interested in understanding the underlying drivers of data manipulation. And while there's several prominent frameworks that describe how to improve HMIS data quality and how to increase the use of HMIS data in decision-making, we found that there weren't any conceptual frameworks or theories that really explained how and why administrative data are manipulated and how one might even intervene to prevent data manipulation. And in order to understand the underlying drivers of data manipulation, we adapted Terran Vian's corruption in the health sector framework. And this was particularly useful because it helped us think about how data manipulation is being rationalized by those who partake in data manipulation, how are opportunities for data manipulation potentially created, and what are the pressures that individuals might feel to manipulate data within a health system. And we also ended up using this framework to present and organize our research findings. Next slide, please. So I'll talk about some very, very high level findings. And I just want to note that there's a lot more nuance than what I will be presenting here. But in general, when we talk about opportunities for data manipulation, we found that opportunities for data manipulation were created when district leadership enforced accountability for performance data, but not necessarily for data quality. And respondents identified 2 main reasons for this. First, they said that district priorities mirror state priorities. And they said that from their perspective, the state prioritized performance rather than data quality. As this quote states, the trouble is if performance is good on the basis of data, no one is going to ask anything. Second, respondents noted that several district-specific challenges existed. For example, limited understanding of HMIS data quality, high workload, systemic corruption. But they felt that the biggest barrier was a conflict of interest that existed. So the district leaders who were responsible for enforcing good data quality were also judged on those same data. And here we see a district staff say, You can look at data to track health programs, or you can focus on looking at the data mainly as a way to save your own job. Next slide, please. District staff also described how performance pressures and the punitive work culture in the health system resulted in pressures to manipulate data. So many of our respondents at the district level described being scolded during meetings. They also described holding their breath before attending their meetings with their superiors. And this quote on the left here explains how these meetings in a way created a perverse incentive to manipulate data. So in some way, data manipulation ended up becoming a coping strategy to improve performance over a very short period of time, but specifically before the next monthly district ranking was released. Next slide, please. Finally, we found that respondents who rationalized data manipulation did so by describing and explaining the social pressures they felt when it was especially obvious that districts were manipulating data. And this was often reflected in the rapid increases in district rankings. So for example, if a district was ranked 50 in the month of October and their ranking jumped to 25, respondents at the district level were very wary of these improvements, and they felt that this improvement was actually a reflection of data manipulation and not necessarily true improvement in performance. We also found respondents who described how job security and financial security for one's family was often used as a justification for data manipulation. But I would like to note here that we also found other respondents who resisted data manipulation, and they did so by drawing on technical reasons for being unable to change data. So for example, this respondent here says, "We are not data generators, we compile data." There were also other respondents who flatly ignored requests. Next slide, please. More broadly, our respondents identified three main factors that mitigated data manipulation. First, they described the benefits of digitizing reporting processes because it increases transparency and accountability in terms of who enters the data within the system, when and where. They also described the benefits of conducting trainings in order to close technical gaps in knowledge, particularly around data entry and data quality assessments. However, according to our respondents, the most important factor was having leadership that not only valued good quality data, but also demanded good quality data in decision making. Next slide, please. So overall, our study underscores the importance of aligning the goals of health actors in leadership positions with those with actors in data units, so that the goals of data quality are not at odds with performance goals. And in the case of UP, this is achieving a high district ranking. And looking ahead, I think to reduce pressures to manipulate data and to generate accountability for good quality data, it's important to empower actors, particularly those in data units, to have sufficient financial as well as decision-making authority to lead data quality efforts without fear of repercussions. And there's also a stronger need to create stronger organizational incentives around data quality, as well as stronger disincentives for data manipulation. And lastly, just reflecting on the analysis approach that we used for the study, I think the corruption in the health sector framework worked quite well to examine issues around data manipulation, but I also think that there's certainly room to enhance this framework to consider other influences and pressures, for example, by the national level, as well as the global level, that could potentially also affect data manipulation. Next slide, please. And with that, I'd like to thank you all for listening.
Thank you very much, Ankita. Very, very interesting presentation. Can I now request all of our panelists to please open your camera and mic? And we will now proceed to the Q&A portion of our webinar. And I'd like to turn over the session to Aaron, our vice chair for today. Aaron?
All right. So good morning, good afternoon, good evening, everyone from across the globe. And thank you so much for staying with us. A huge thanks to our esteemed panel for taking us through very rich and insightful experiences on how they've applied theory and conceptual frameworks to be able to have a better understanding of various health system policy challenges. So we have a limited amount of time, and plenty of questions have been flowing in. So we'll cover some of them, and I apologize in advance if we will not be able to cover some of the questions that you have raised. Thankfully, some of our panelists have already responded to your questions. So we'll do this in two parts. So the first I'll do a first round of questions that are specific to the different panelists. And then once that is done, we'll open the floor to more cross-cutting questions that we can be able to all have discussions around. So without further ado, allow me to begin. There's a question for Catherine. So there's a question. So what are the advantages and disadvantages of using theoretical bricolage rather than pure theory studying HPSR? So that's a question to Catherine. To Shreya, one of your questions was already answered, but there's a question here. What, if any, differences did you find in the perspectives and power of core government health staff versus those in NHM and NUHM? For Kevin, to what extent is a leftist, socialist, Marxist political orientation a necessary component of the political will necessary for this focus on primary healthcare? And then we have a question. Yeah, so why don't we begin with that first round first, and then in the order that I've just used, and then we will be able to pick up more questions as we move along. So Catherine, over to you.
Thanks for that question. I think in answering that, one has to also, and that's not the level of depth that we went into in this initial paper and this initial analysis, but it's definitely sparked some further thinking about that. I think one has to look at these sort of different types of bricolage, perhaps, because one of the findings in our paper was that some of these more open, broad frameworks, like the stages heuristic policy cycle, or like the policy triangle, do lend themselves well to be used in bricolage because they offer a sort of broad framework of the concepts, and then researchers can use more specific theories to feed into those and unpack and do some more examination of some of those concepts in action. So that's one kind of bricolage. Whereas there's other kinds, like we saw in one of our papers by Pruce and Hickey, and was published in 2016, looking at this concept of elites and political settlements. And they did some theoretical bricolage. So it was a little more complex with some broader theories, but recognizing and working with them the gaps that they had and the advantages that they had in bringing in additional theories to fill those gaps. So I think in working with bricolage, if researchers have the opportunity to have that deep engagement, it can offer quite a bit of advantages of a bit of a more complex and rich theoretical lens with which to approach their problem. However, I would say that one of the advantages of working with the singular theory, as we've seen in some of this work, is perhaps the advantage of doing some more comparative analysis and building a body and a state of the art of knowledge that can be looked at against within that comparative lens, things that have been analyzed with a certain theory. And that's one of the recommendations we make in the papers, looking at some of the theoretical reviews that have been done in public policy. For example, there's been one done on multiple streams theory, one done on advocacy coalition framework. And so there would be a great advantage into doing some sort of review like that within global health policy and see the range of ways people have been working with a specific theory and trying to identify the advantages of that. And finally, I would just say, if we want to learn more about that, we really need to encourage that theoretical reflexivity of authors in their publications to be identifying that learning and those advantages and those gaps and actually as a field contribute that not only back to our own field, but back to the public policy literature more broadly.
Thank you. Is it Kevin or yeah, Shreya? Shreya, you can go next.
I can. So thank you for the question, Sarah. You're absolutely right. Like, within the Indian health system, for people who may not be familiar, there's the more permanent staff, which is associated with the Department of Medical Health. And then there's this National Health Mission, which is mainly contractual staff. And both these staff like work together hand in hand at the, from the facility level to the state level. You're right, absolutely, in terms of the HRH issues experienced, by staff that work with, that are contractual and work with the NHM are very different from the ones that work, with the directorate or, with the more regular staff. And in terms of power, I would say that both, I think it really depends on what, which policy we're talking about, I think, because both in their own sense have some level of power, because the NHM has its own operating machinery, they have their own HR department and can make their own independent HR policy. Right up to the state leadership level, the mission director of NHM gets, an equal seat at the table as somebody, is also senior bureaucrat, so within the bureaucratic system gets some amount of power as well. I think the real issue, in my perspective or experience, is this absolute fragmentation of the system, where there is a different NHM and then, when employees are working side by side on different contracts. So in fact, one of the policies that we proposed in the HR strategy was the integration of the health workforce, where, contractual and regular staff are able to work together better. And we found actually that policy ended up being one of the more contentious policies, where people had a lot of different perspectives, because it's actually quite complicated. There are a lot of different aspects associated with, integrating this actually now very large contractual workforce. I think it's almost equal to the regular workforce now. So it's becoming a rather pressing, even a political issue now, that, there's this large contractual force that they're not regularizing. So I think it's more about that. But to go back to your question, I think both, regular as well as NHM staff have, in their own sense, some amount of power to influence policies that are concerning with themselves. It's the integration that I think needs to be thought about. Thank you.
Thanks. Kevin, over to you.
Yes, thank you for the excellent question. So the question was about to what extent the leftist or the Marxist orientation of the TPLF, the party that eventually was the core of the ruling party, to what extent did that drive the investment in primary healthcare? I think it's clearly important, and globally there are many cases where leftist movements, the Sedentaristas in Brazil, or origins in primary healthcare in Kerala or other places, have clear links to left-wing parties. The TPLF was clearly, a Marxist party, but I don't think it's really the explanatory factor here, because the party they replaced, the regime they replaced, was also a Marxist regime, the Derg. And that regime also had a policy of primary healthcare and community health workers, but was essentially completely unable to implement it. And so when they were replaced by another party with left-wing orientation, and yet the implementation is at national level, then I think that seems like it can't really be the major driving factor in the Ethiopian case. I do think the broader kind of constellation of ideas that was at the heart of sort of how TPLF and EPRDF thought about Ethiopia's developmental trajectory, it's quite linked to these to their Marxist conceptualization of sort of broader historical processes, but I think other elements of that are more distinctive. So the focus on rural areas, the focus on, when resources go to rural areas, they must be used in a programmatic rather than clientelistic way, and even ideas about sort of incorporating rural populations as opposed to co-opting local elites. And these are sort of very distinctive aspects of the thinking of the regime at the time. So I think the broader kind of left-right dimension is important, but it's actually an element of continuity with previous regimes. So I don't stress it that much in the explanation. Thank you.
Thanks. And a question for Ankita. So can you give examples of what it looks like to demand or incentivize good quality data from your experience on the paper?
Sure, that's a great question. So I think in terms of examples, one of the main examples was leadership, particularly at the district level. So the district magistrate demanding that data be reviewed during these data quality meetings, requesting that supportive supervision be conducted. So having leadership that really emphasized processes around data quality meant that folks within the district level tended to prioritize those processes better. But a particular example that really sticks out to me was using district rankings as a way the policy intended for the district rankings to be used, which is look at the district rankings, identifying low performing indicators, and then based on that, developing action plans. And when we had leadership in those positions that actually demanded people to investigate why there's a low performing indicator, to look at reasons of that. So for example, is it HR? Is it the lack of health commodities? Is it procurement is delayed? So having district that identified those problems actually encouraged people to use data rather than having district leadership basically reprimand them for low performing indicators. So it was really demanding why performance is low and allowing and creating an environment where I think poor performance wasn't necessarily seen as bad. It was just reality. And I think there was often this confusion between good data being high performing data, not necessarily good data quality. So I think in short, I think the biggest example that came out from my research was around having leadership that encouraged people to report real data and really try to understand if performance is low, investigating why that is, so that people are encouraged to actually report real data versus over-report.
Great. So we going to do one last round of questions, and I want to ask that the panelists take exactly 1 minute or less to answer, and it's more of helping us to wrap up and reflecting on our experiences with our empirical papers. And so the question is, just reflecting on your own experiences, what have been some of your dilemmas, as far as picking the right theory or concept to be able to, advance, whatever question you have on policy. And secondly, what recommendations would you have to expand on, build on the theories that you picked in your different studies? So one minute each. Gilbert, I'll start with you.
Okay, thank you very much. And really, it's a very interesting question. And I really had a lot of dilemmas actually coming out with which particular theory to use. And that was what I even had to end up applying 3 different theories. But when you look through all the theories, you realize a bunch of them have been applied at the global level. So at the local level, like I was doing a regional level policy analysis, virtually you have little applications of those theories there. So which one suits very well became a problem. Second, you realize that many of them are used to actually explain how policy issues gain political attention, but how they lose political attention has not been actually studied with those theories and all that. So combing through all those theories, you could also see that there are a number of things that are cutting across a number of them. So you see political context is everywhere. So my thinking has always been, is it not possible for us to have a synthesis that will actually draw on all the various elements that have been presented from the Walt-Engelson model through all the Schiffman models and all those models to come out now with a standardized framework, perhaps on all those elements that are available. So that is what I've been thinking about. And if I had the opportunity of doing that, I would have submitted a paper on exactly that. This is standardized model drawing on all the various theories. Thank you.
Thank you very much. And there'll be plenty of opportunities to continue engaging on this platform. Catherine, over to you.
Yes, well, I mean, I will just maybe perhaps draw as well on my own experience when I was conducting my PhD, because I really entered this idea around synthesis frameworks in public policy through my doctoral research, where I also developed a synthesis framework. So I think one of the challenges in doing that kind of work and finding something that is appropriate for the field that you want to look at and for some of the questions you want to look at requires an enormous amount of time. And I would say that time is not something that we all have a lot of, and that we can afford to spend a lot on theory development. So I think there is an issue, a broader issue on sort of, I would say, sort of socialization of global health researchers and how we're trained and what we're given access to and how we are formed, that formative experience of working with theory, and which ones we are introduced to early on in careers. So I really like this comment that Gilbert just made around, we need to have a broader look at those theories that we're using and really question them, question where they're coming and where we're using that, where they're coming from and where we're using them. We want to encourage interdisciplinarity, but not at the expense of not looking at some of the more local or regional and more global South appropriate theories that exist to look at some of these questions. And so I would say that we also need to be looking, it goes back to one of the points that has been made in the introductory panel of this series around our sort of knowledge models and frameworks and also journals and where we're looking for this information. And so if we're looking in the same places, there is also a risk that we're just creating a sort of small circulation of a core set of ideas that have become, we've become reliant on using, and then those are reproduced because that's what's accessible, that's what's been operationalized, that's where young junior researchers and early career researchers are oriented to get their inspiration for their work. And so I think we need to have some critical reflection as a field on that cycle and being more diverse and inclusive. And yes, I'll end with that.
Okay, thank you very much. Over to you, Shreya, for 45 seconds now for the rest of the team. We've run out of time.
Because I think Catherine actually highlighted a lot of the things that I wanted to say in terms of the time and the practicalities of like actually doing the research and actually being under that kind of pressure from partners and like identifying and delivering results, but at the same time making sure that your work is like grounded in sort of in a theoretical or a framework approach. And I think what would be helpful is also thinking about the kind of methods that are available to us. So if we do accept some, basic theories that are available to us, there are, Catherine in her research presented some of the more popularly used theories. But I think in terms of thinking about how to sort of, when we actually, think about applying it to a context or, developing recommendations, using that, taking all of those things into account. I think it's the methods, that the experience of the methods, I think, is what we thought was a little bit of a challenge in terms of how do you actually do this. So you recognize the importance, for example, of actors, but like how do you actually go around taking those things into account? And maybe some, in terms of recommendations, how do you sort of map those methods onto some of the more popular frameworks that are available? Stop there. Thank you.
Thank you very much. Thank you very much. Kevin?
So I'll be very brief. I think the two things I would say are, I did a case study, but I think we learned much more from comparative work, so paired or multi-country case studies, and that entails collaboration, and so matching with other country specific researchers. Second thing that I always find in global health is that there's usually a large country-specific political science literature that we could learn a lot from, and we usually don't read those papers in books. And I think we could inform a lot of our thinking about the health sector if we did. Thanks.
Thank you very much. Ankita?
I agree with Kevin's point. I think it's important to look at theory which is out there in different disciplines. So for example, when we were trying to understand data manipulation, we focused on looking actually at corruption frameworks, because those have been better developed. And that was mainly because there are several parallels that exist between, for example, corruption and data manipulation. You have people who are misusing their power or coercing other people to misuse their power for private gain. Like corruption, data manipulation happens quietly. And what's really interesting is that if you look at Terra and Beyond's corruption in the health system framework, it's based on the fraud triangle, which is developed by Donald Cressy. And that fraud triangle actually comes from risk assessment and fraud literature. So it's really interesting to be looking at frameworks that work really well in a completely different discipline, but that also have cross-cutting applications to our work in the health sector. So I think being able to access those types of conceptual frameworks and thinking about how do we apply them, but of course adapt them to the local context to study our research questions, I think is a really powerful tool, which we should all work towards.
Thank you very much, everyone on our esteemed panel. So great presentations, excellent reflections. So over to you, Kathy, to conclude.
Right, thank you very much, Aaron, and all panelists. It has been a very excellent discussion. And I'd like to end by highlighting the challenge ahead of us. Before we went live for this panel, we were discussing about what's happening to our end, our part of the world. And I think we've seen how events have unfolded this past months, and we see the big challenge ahead of us. And I'd like to go back to the point earlier about our reflexibility as researchers and our research being part of instituting change, asking questions. And I hope that forum like this will allow us to really think beyond what's and challenge what the kind of questions that we're asking and the kind of perspectives that we're putting out there as researchers. And this highlights the importance of not exactly having webinars like this, but it's really continuing engagement with ideas, as well as having platforms for us to deepen our scholarship in terms of the theories that we use. Now the movement towards decolonization, having more ability to compare findings across settings, as well as having tools to deepen our appreciation of context. And I think this is a challenge, not just for the researchers that are here, but to the next generation of researchers. And that's a challenge for those of us, particularly who are teaching and who are putting our work out there. So I would like to encourage everyone to continue the discussions. If you would like to engage with the researchers that presented tonight, they're tonight in my part of the world. It's probably very early morning for some of you. So I would like for you to, I'd like to encourage you to continue discussing with them. Their profiles are on the website of this forum. And I'd like to take this opportunity to invite you to the last panel happening on December 1 on policy lens on complex health and social welfare problems, to be chaired by our colleague Marcia Orchil. So with that, I would like to thank all of you, and the recording of this webinar will be posted on our website very soon. Thank you.
Thank you.
Thank you.
Thanks, everyone. Bye.
Bye-bye, everyone.
Thank you.